Hi, welcome to the Pediatric Endocrinology Question and Answer Part 1. I'm Dr. Lugo, one of the pediatric endocrinologists from the Morris Children's Hospital in Orlando, Florida. And this lecture is just meant to cover high-yield questions that will benefit pediatric residents, medical students, family medicine residents, pretty much everybody who's getting ready for the USMLE Step 2 and Step 3. I kind of added some of the questions based on general endocrine, growth and undergrowth and overgrowth conditions. And I already have some lectures just in case you want to go back and look for more information. Now, I'm going to have the questions stem first. Not all of them have multiple choice stems, but I will try my best to kind of guide you, give you a little bit of hints and tricks, so that way you'll be able to tackle these questions. Okay, and so my first question is saying that father's height is 72 inches or 6 feet tall, and mother's height is 64 inches. What would be the mid-parental height in the event that they have a daughter, and what would be the mid-parental height in the event that they had a son? And so what would be the result? Now, for this, we need to understand the mid-parental height formula. And this is something that they're probably going to ask. So make sure that you understand that the mid-parental height is the genetic potential between mom and dad's height. And it kind of plots the result on the growth chart at the end of that growth chart. So it gives me an idea of what's going to be their adult final height or their genetic potential. Now, keep in mind, whenever we talk about this, we talk about standard deviations, and a standard deviation for pretty much sons and daughters would be about 2 inches or 6.5 centimeters. So every single time that you're giving an answer, make sure that you have to add plus or less 2 to 4 inches. And so if you have a male and you need to calculate the son's height, all you have to do is make sure that mom's height gets to become the equivalent of a male height. And so in this case, we would add 13 centimeters if you're doing centimeters, or 5 inches if you're doing inches. And then you divide by 2, so that way you can get that mid-parental height for a male. Now, if you're calculating a female, you would have to do the same, but you would have to make the father's height an equivalent of a female height. And so in that sense, you would take away 13 centimeters or 5 inches, depending on what measurement tool you're doing. And remember that at the end, you consider 2 standard deviations. So to answer the question here, you would say that the daughter's height would be 64 inches plus 72 inches minus 5, and then you would divide that, giving out a final result of 65.5 inches or 5 feet high, 5 feet 5 plus or less 2 to 4 inches. And so for the son's mid-parental height, you would do the same, but you would add 64 inches plus 5, and then you would add the 72 inches from dad, divide by 2, and it would give me an expected adult height of that son for 70.5 inches or 5 feet 10, 2 to, plus or less 2 to 4 inches. And so that would be something that is important, because my 2 to 4 inches, they depend on good sleep hygiene, good diet, and basically having very well exercise. Number 2, a child presents with normal growth velocity, but is tracking at the 3rd percentile on height. My mid-parental height is at the 50th percentile. Parents refer that mother had a period at age 16 years and father started shaving in college. What is the most likely diagnosis? And my options are constitutional growth delay, familial short stature, growth hormone deficiency, and idiopathic short stature. Now this one might seem a little bit complex, so I'm going to try to break it down for you. The first thing, it's saying that there is a normal growth velocity. So that means that there are no accelerations or decelerations in linear growth. This is actually showing that it might be something normal. Now, the second thing that it says is that mother had the menarche when she was 16, which is a little bit later than what is expected. Keep in mind that the first period or menarche is usually on an average of 12, 12 and a half, 13 years around the globe. And then the third thing that they say is that the father started shaving in college. In other words, they're kind of telling you that they're late bloomers, but they might not use the term because it might be a giveaway. So in here, you would have to think of maintenance of growth velocity. And if you are keeping your growth velocity, you do have to keep in mind that this could be constitutional growth delay or familial short stature. Now, if you have any growth deceleration, of course, you have to consider growth hormone deficiency and idiopathic short stature. Now, for constitutional growth delay as well as familial short stature, growth velocity is never a problem. That means that the kid is going to be able to meet around 5 centimeters in a year or 2.5 inches in a year. And the mid-parental height is always met. I'm going to give you examples right now. So if you have constitutional growth delay, and of course you see this growth chart, it all makes sense. You have a child that is pretty much growing accordingly if you compare all the points in time, and eventually crosses all those percentiles during puberty around 13, 14, 15, 16 years, and then reaches out a normal final adult height that is pretty much similar to the mid-parental height. However, if you take this kid at any point before that growth spurt, you might get very concerned because you might see, oh, it might be meeting 65 inches as an adult because it's tracking pretty much in the third percentile overall. And so if you think that the mid-parental height is 70 inches, you might be missing in here a lot of inches. And so in this sense, if you have a history of parents being late bloomers, for example, if they tell you that they have dental changes later in life, and then you have a bone age that is delayed, you might be able to give them some reassurance before you actually get to those teenage years. So in this case, if you do a bone age around age 6, and the bone age is kind of tracking along that little purple line dot that I placed in here, saying that the bone age is saying that you're kind of like 4 years, maybe 5 roughly, then that means that that child is going to be growing according to that bone age, and eventually is going to be able to meet a final adult height that is not going to be affected. Now, in terms of familial short stature, you will see that the kid is also tracking at the low side of the growth chart, and it's saying that it's pretty much going to be 65 inches. But then when you do the mid-parental height, and the expectations are basically the same because mom and dad are also on the short side. In the event that you do a bone age in these cases, you will see that the patient is meeting that same chronological age. And so if you want to read a little bit more about it, or if you want to watch some YouTube videos, I saw these two. I thought they were really, really good. But basically that would be my idea. So that way I can know the difference between constitutional growth delay and familial short stature, also known as genetic short stature. Now, for growth hormone deficiency and idiopathic short stature, you will see that growth velocity is a problem, is delayed, and the mid-parental height is not met. Those cases will definitely will need further workup. Now, question number 3. A 1-day-old baby boy is evaluated in the nursery unit due to macroglossia. He is at risk for which of the following? And you have your options of congenital hypothyroidism, omphalocele, and Wilms tumor. Now in this case, keep in mind that we're saying that the kid went to the well baby unit or the nursery unit and he's already showing macroglossia, which is an overgrowth condition. So I want you to keep in mind that this is a big finding in the physical exam of a neonate. And so in endocrinology, whenever we talk about midline abnormalities, anything that is from a high arc palate, optic nerve problems, midline or central tooth, micropenis, umbilical hernias, this is considered to be a little bit of a red flag and we'll inquire further workup. Now, going back to the macroglossia, there is this beautiful algorithm in here that was published in 2012, and it talks about BWS. So I want you to always keep in mind that for macroglossia, we kind of need to have that clinical thinking for Beckwith-Wiedemann syndrome. And so this is the journal in case you want to look a little bit more about causes for macroglossia. But keep in mind that Beckwith-Wiedemann syndrome is an overgrowth disorder in which you will have macrosomia, hemihypertrophy. As you can see in this drawing, the baby seems to have a longer lower limb compared to the other side. One of them is very, very flexed. The other one is more stretched, and somehow they seem like they're from the same length. And you might see kids that are turned, and so they're giving you the idea that one of the sides is larger than the other. You can also have visceromegaly, including hyperinsulinism because you have problems with the pancreas, and of course, a macroglossia. And so in this case, patients can show with low blood sugars. They will need to be monitored after birth as they have a risk for other overgrowth conditions. And one of the overgrowth conditions that I want you to keep in mind is called nephroblastoma or Wilms tumor. Another one of them would be rhabdomyosarcoma and hepatoblastoma or hepatoblastoma. And then congenital hypothyroidism, just so you have an idea, at birth, you might not see a lot of changes. You might actually start noticing a prolonged jaundice after birth, persistent posterior fontanelle, and an umbilical hernia. Now, for these cases, we do have the newborn screening test, which is a heel prick test, and is sent to every Department of Health across the United States, and so they are able to give us an idea before we actually see clinical findings in these patients, not only for hypothyroidism, but we also have it for congenital adrenal hyperplasia and many other metabolic disturbances. Regarding weight concerns in children, it's a little different because our main concern is linear growth deceleration. And in the first 3 years of life of congenital hypothyroidism, if it is untreated, we can actually have problems with their cognitive development. So I wanted to share with you this picture because you can see that the patient at your left is having edema around the eyes, having a sunken eye appearance. There's also like a little bit of a broadening of the nose, edema, coarse features. And then of course, as soon as you start treatment, you see the patient to your right that looks completely different, but it's actually the same patient, but completely improved. And so for your boards, this would be your fourth question. And it's kind of like a dual thing, so that way you know the difference. The most preventable mental retardation in newborn babies would be fetal alcohol syndrome. We know that avoiding alcohol during pregnancy will actually avoid this problem. And then the difference between this one and the second part of this question is that the most treatable cause of mental retardation in the newborn baby would be congenital hypothyroidism. And this is because we know that thyroid hormone is very important for our central nervous system development. And so when it's missed, they say in theory, you can lose up to 1 point of IQ per day missed. And so this is one of those few things in which we will actually rush for the follow-up appointment. And as a pediatrician, you will see that we want to start treatment right away. And then my last question for the day would be, when should a baby double their weight and when should they triple? And my second part of it would be, what about the height? When do we double our birth length and when do we triple it? And for this one, I feel like it was a little tricky because I know that in my talk, I talked about the birth weight and the gain, but I didn't talk about the length. So let's just cover it right now. First of all, for my birth weight, we know that we double it at 5 months and we triple it at 1 year of age. So in other words, if I have a baby that was 7 pounds at birth, it will be expected for that baby to be 14 pounds at the 5-month checkup, and it would be around 21 pounds at 12 months of age. And this is important because if we do have a suspicion for somebody having failure to thrive, as well as we have concerns for overgrowth conditions or genetic causes for obesity, we will see that they're not meeting this part. As for length, we know that we double the birth length at 4 years of life and we triple it at 13 years. And in here, we would say that if the birth length was 20 inches, the baby would be about 40 inches when it reaches 4 years of life, and it would be about 60 inches or 5 feet tall when the kid is 13. And so that'll be it for now. I hope that you enjoyed these 5 questions, and please let me know if you have any questions or if you want to give me any feedback. Thank you.